Dr. Rachel Lampert. I'm the editor of the Cardiac Rhythm Management CardioSource community. Here with me today I have Dr. Ann Curtis, who's the chairman of medicine at the University at Buffalo, to talk to us about the BLOCK-HF trial. Dr. Curtis, tell us about the rationale for the trial, the design, what you found.
Thanks, Rachel. The reason we did the BLOCK-HF trial is that we know from clinical trial evidence that right ventricular pacing can be detrimental to patients. But what we haven't been able to determine yet is whether or not there's any other way to pace patients that would be superior to that. We know that when patients don't have AV block, you can use different kinds of algorithms to minimize ventricular pacing. But when somebody has AV block, you can't avoid pacing the ventricle. So there have been some attempts at using, for example, other sites for pacing the ventricle, but there's really no good evidence that that's superior either. So for the BLOCK-HF trial, what we decided to do was look at the use of cardiac resynchronization therapy compared to right ventricular pacing to see if CRT would be superior in patients with AV block and LV dysfunction. The primary endpoint of the trial was a composite of mortality, heart failure-related urgent care, or a significant increase in left ventricular end systolic volume index. So we enrolled patients in the study, implanted the devices, and the patients could have gotten a CRT pacemaker or a CRT defibrillator, and they would have gotten a defibrillator if they also met indications for primary prevention ICDs. Now I want to emphasize that any patient who was already indicated for CRT therapy by current guidelines was not eligible for the trial. So we implanted the patients, optimized medical therapy, and then they were randomized in a blinded fashion to RV versus biventricular pacing, and then followed prospectively. And what we found at the end of the trial was that for the patients who got the CRT devices, there was a significant improvement in outcomes, and so from that composite endpoint, they did much better. And so it was a gratifying end to the trial to see that we could actually impact outcomes in patients who have AV block by doing the CRT pacing instead of right ventricular apical pacing.
So Ann, how do you see this impacting your own practice, future guidelines?
It's been interesting because one of the reasons why the trial went on so long is that there were more and more electrophysiologists who seem to be leaning towards CRT anyway. And I always think if we're going to go change guidelines, it's so much better if we actually have clinical trial evidence that can drive the good decisions. And so what we see here is that by showing in a large prospective randomized trial that outcomes are better with CRT, that actually affects my practice, because now I believe that that is the right thing to do for patients who have LV dysfunction. Now, given that, you still have to change the guidelines, and so I'm not the one who writes them, so we have to see what they say, but I would presume that the guidelines would be changed based on the results of the trial.
Thank you, Ann, for this really interesting study and an interesting discussion. I think this is really going to impact the way we practice care for these patients in the future.
Thank you, Rachel.